When was it placed?
When was it placed? Absolutely.
Does it draw blood back?
Does it draw blood back? Absolutely. So just because you have a line here, you should be able to draw blood back, but you may not. Doesn't mean it's not sitting in the right spot. Just mean you're not able to draw from it. What else?
When was the last dressing change?
When was the last dressing change? Absolutely. So all that stuff I want to ask my nurse. I want to know, you know, if they have a line, number one, how many lumens I got, okay? Because it's not very helpful to have a central line and what? Have one lumen. But sometimes, you know, they will put in just one lumen. It's better if you have 2 or 3 because you have different access points, okay? If you got a one central line and it is a single lumen such as this, that is, you know, we hope it draws blood and stuff like that, but we really don't have a whole lot more access than just a little peripheral. It's central, but I don't have any more. Usually you have, when they're talking about triple lumen, they're talking about the number of lumens that you have. This is single. If I had 3 of them, that's a triple lumen. Okay, so you can have a pick, but you can have a, you know, do you have a dual lumen or a single lumen pick? Okay, lumens mean how many access ports do you have? Okay, does that make sense? Mm-hmm. Okay, so what else would you want to know?
Is he receiving anything through it?
Absolutely. Is he receiving anything through it? Okay, is he receiving anything through it? So that tells me if I need it or if I don't need it, right? Okay. So I come up upon this patient. This patient has a, and they talk about central line dressing change. Sometimes you'll hear them say central venous catheter, CVC, PIC. All that stuff really relates to the fact that it's sitting in a central location. They'll say central venous catheter. They can call this guy central venous catheter. They can call him a single lumen central line. Okay? All this means the same thing. Okay? All that means the same thing. When you have a central line, usually hospitals have protocols on who can change them, how often they should be changed. It changes from, like they may just write an order. We do have orders here. They may just write an order, like she has maintained central line placement, okay? Central line dressing, sterile dressing change, Q7 days, or PRN. You may need to change it more often. Sometimes they have a protocol on who changes the line. Does the nurse change the line, or do you have a PIC team that comes along, IV access team that comes along and change those lines, change the dressing? Definitely notify your healthcare provider if you got signs and symptoms of infection. Another thing about a central line, if you have a central line, who can draw blood from?
Nurse.
The nurse and only the nurse. That's your job, okay? If you have someone that comes up, the phlebotomist comes up, and your person does have a line, then you tell them my person has a line, okay? And most times the patient tells them I have a line. And then you can go in according to your protocol, because some protocols, they don't want you to draw from a PIC line, you know, because that's a narrow lumen and you might clot it off. But if your protocol is that you can draw blood from your central line, then you have to draw it. You can't send a phlebotomist in there to draw blood from your line. Okay, that what you can do is draw the blood, label it up in front of the phlebotomist, and then they take it down to the, you know, to the lab or whatever. Okay, does that make sense? Mm-hmm. Okay.
And for most multiple lumen catheters, it's like color coordinated, or can you just draw from anyone? Like sometimes it's red, blue, white.
You can draw from anyone, but it's when you have a triple lumen, and that's a little bit about when you have a triple lumen, you have a brown port, white port, and a blue one. Well, I know if I got a blue port, I can hook them up to CVP and get me a central venous pressure. And and that's for 4th semester. That tells me a lot more. So I can do something with that blue port. You know I can do more from that blue port than infuse medication and draw blood. If the doctor says, you think he's septic and I want to get a central venous pressure, I can hook it up only to that blue port only and give me my central venous pressure. Okay, if that makes sense. So yeah, they have different color codes and things like that. Okay, you okay, Ashanti? You look like you're not feeling well.
I'm okay.
You okay? Okay.
I was thinking the same.
Yeah, but we looking for these folk ain't feeling well. I'm like,
That is her normal face, y'all.
I'm telling you, don't try it now. You like it's the end of the semester. This is truly the time in which students start falling apart, and your professors do too. Just if we're human and we know, you know, it's we can only run at this breakneck speed. So if you got to change your central line dressing change, and it's day 7, and I got a protocol that says I need to change it, then I need to change it, okay? So what I need to do, come in, first of all, assess my patient, okay? Which way do you want this patient when you're changing the central line? Which way do you want it?
Away from it.
Huh?
Facing away.
You want his face turning away, and if he can't turn his face away, what do you want to do?
Put a mask on.
Put a mask on, okay? So we want to explain the procedure, let him know what we're going to do. What else do we? What about his position?
Sitting up.
You want to lay him as flat as possible. You may not be able to go flat, but you would like to lay him as flat as possible. Why do you want to do that?
Because of the air bubble?
That's right, air embolus. Go ahead and kill your patient with an air embolus. Okay? So you want to lay him as flat as possible, as flat as he can tolerate it. He may not be able to stay, you know, go with his head all the way down. But as flat as possible, if you can. So if he gets there and he looks like that's about all he can do, that's all he can do, okay? Another thing that you're doing in terms of putting the mask on him so that he won't cough into his own sterile field, okay? Because he can do that. He can cough into his own sterile field once I expose him. Anybody, and just for sake of if you have somebody with a wound that's here, make sure you're having that person turn their head to cough, okay? Because other than that, they're coughing right into their wound, okay? And that's how you get infection from what? Your normal flora, what's in your mouth, okay? That's how burn patients get infected. They infect themselves, but they infectious to their own selves, okay? So this is your triple lumen. This is a single lumen. And like I said, normally they're sutured in, okay? Normally they're sutured in. They may not be, but you need to know if they are, okay? Most times they're sutured in and things like that. So you come into your patient, perform hand hygiene. Tell them what you're going to do. What do you want to tell this person?
Your dressing's been in for 7 days. I'm going to change it.
Okay, your dressing's in there for 7 days. You won't let them know there's nothing particularly wrong, right? It's just something that we do protocol. Okay, so I'm going to change your dressing. I'm going to identify his name, date of birth, allergies. In particular, allergy to who? Chlorhexidine. Do you have an allergy to chlorhexidine? He's like, no. Thank you. So he's wonderful. Okay. Another beautiful patient.
That's a question.
Huh?
That's a question.
Okay.
What about the iodine?
You asked him about iodine too. Sometimes we don't. These dressing change kits don't contain iodine. But if he has an allergy to chloroprep, you might have to change to something that's like iodine or something like that. Okay. That's when you change your protocol. Okay. Most of these have chloroprep in there. Okay. So I'm going to come up and I'm going to inspect this. They have caps here. When they're talking about changing the caps, you have protocol on these caps because these caps can be changed. These are the areas. And most times there's a protocol to either change them every 3 days, change them every after infusion. A lot of times they have like a green port and you just twist the green cap off, put a new green cap on. So you need to know about your caps as well because these caps, they come off, they twist off. Okay? Okay, they twist off. Okay, and then you can put them back. You know, like I said, you might be changing the cap. Sometimes you need to get rid of the cap. You can flush through these caps. If you got a flush medication, you can flush through these caps. But there's a protocol, and they'll tell you on your protocol how often your caps need to be changed. Some caps have to be changed if they're the green cap. They have to be changed every time you infuse a medication or something like that. Okay. So I come in, I try to see if I see any signs of symptoms of infection. That would be like redness. Is it sore? Is it warm to touch? Okay. And then another thing, pay attention to the amount of drainage that you're getting around this thing. Okay. Is this person just sweaty or am I getting a lot of drainage around this site? Okay. Because that still may be an infectious process. Typically, with this type of dressing, you will see that they'll be sweaty underneath or something like that. So it'll appear moist, you know. So that's okay. So at that point, he's not allergic. I've told him about the procedure. I position him as low as his head will tolerate. Okay, if you got somebody that's exposed, go ahead and put something across their chest, you know, so they're just not exposed. To, you know, kind of cover them up or whatever. Some modesty will do. So then I have to take these dressings off. What does it say? Where's my sheet at?
It says on there measure too.
Yeah, measure. So you do have your thing? Yeah, okay. So you can measure. You need to measure. And how far are you measuring this from? From the insertion site down to the lumen. Be careful with these that we have. Let me tell you about. They're not sutured. Okay, so
they will come.
They'll come right out with your dressing. I mean, you be pulling this thing off and you have it right in your hand. Okay, if that happens to you, just say, hey, okay, this is normally not supposed to happen. Normally not supposed to happen. So your measuring tape, it doesn't have to be sterile or anything like that. You can measure, like I said, once you get started, you can measure from here to here. Tell them how far it is from it. This is actually 15 centimeters. Okay.
Why do y'all think it's important to measure it?
To see how much it came out or if it did.
Yep. See if it's changing, absolutely. Because it can very much look, you know, like I said, it can look. And these are, like I said, your sites for that is your internal jugular vein. This is subclavian. And like I said, you can have a PIC, or like I said, you can have an implanted port, which sits right here, okay? So, depending on where you're sitting at. So we got to get this off. Now, you might have a little bit problem trying to do this, but I usually just you can roll this back. What does it say on the sheet?
Pull it towards the...
Yeah, put it towards the line. And the reason why you're doing it is rolling it back this way. Why? And you don't want to pull it out. Okay, you don't want to pull it out. So you need to expose it. And it takes quite a bit sometimes to loosen up. Sometimes you have to use an alcohol wipe to do it. And hold on to this right here. Well, once again, these are mannequins and things like that, but they sometimes stick really well. So yeah. Sometimes they have a adhesive remover you can use. It just depends on how well this thing is stuck. It's been stuck pretty good. Huh?
I'll take your choking one for this.
Fingers over his throat.
That would be a kind of block his airway.
Mm-hmm.
You okay? You okay, sir? Sponsor. Yeah, you know, when your students and first starting nurses are like, what, the patient unresponsive? Let me go try it.
I'll do this, I'll do.
That's pretty good.
You want some next pieces?
He might benefit from that. He just has to be that aggressive, but I guess so.
I'm kind of running out of tape here, Professor Bryant.
What's he say?
I'm running out of tape here.
Running out of tape. Okay, well, you're going to have to get another. Because you see how this is coming out now?
Mm-hmm.
It's going to pull right back out. So you don't want to do that. So where are we at, guys? What'd you say? Open the
Didn't
shoe.
she say to hold on to it and then pull the tape out?
Kind of loosen it, take it down.
Yeah, well, this is it's not stuck. This one you don't have to give it back.
Yes. Can we get an X-ray?
You might need one. That wouldn't be a bad idea. Okay, so that's not gonna work. So let's do this here. So what else do I need to get from your hand hygiene? Is my gloves. What else I need to do, guys? I'm not reading the sheet.
Assess the site.
Assess the site. Okay, it has no redness, no drainage or anything like. What else do I need to do? I have to get this dirty part from here, right? So hold on to this, okay? This is where you just need to lift up here. And this is kind of goes out it. What side is supposed to be down, Rudy?
The white side.
The white side is down, okay? So you can get rid of that. Okay, sir, I'm ready to start. Don't go anywhere. So you see what's in your tray, what's available to you. Make sure you get hold of your mask, because you need to put a mask on as well, okay? You cannot sneeze in this man's central line. It's not good. If you got glasses, make sure you adjust your glasses, okay? So your mask, there's a wire up top, and then there's a soft end. The wire goes across your nose. Okay? Now, do I look official?
Mm-hmm.
Mm-hmm. I'll put that there. This here is a good tray because it actually has like a, what would be like a sterile field, I guess. I don't know what this is. It's kind of a balled up sterile field. It's balled up, but it works. Can somebody get that for me? You can open up your biohazard patch. Ooh, these are kind of stuck here, huh? Oh, gosh. And you can dump it onto your sterile field. Well, you can, if it'll go. Okay. Put your gloves on. Everybody's pretty cool about putting gloves on now. Student. What's the matter, student? You okay? Y'all know y'all got that shaking going on.
Especially when you're putting that cannula.
Okay, so what is this? Is this a dominant, non-dominant hand on? It goes like this. It's time for a break.
So guys, if you need bigger sterile gloves, just make sure you bring.
So now I can go in here and play with this all I want. This is your chlorhexidine. To activate this, you have to squeeze it and squeeze it down. Okay? And then it'll come to the surface. Okay? That's the biggest thing. You got to hear it pop. Okay? The alcohol swab you may or may not use. Sometimes they're not using as much alcohol. What this is, directions. They do have you'll find this. They don't use this anymore. That's because we have a bio patch now, but they used to. Little piece of gauze and finally that. Okay. So when you squeeze this down, move to your patient. Which way you want to clean them?
Inside out.
Nope.
Circular.
Yeah. Inside from the circle, then
Nope.
out.
Absolutely. Nope. This is the way. This is chlorhexidine. You want to scrub this back and forth.
Oh.
I got to hold on to this. This is chlorhexidine. You just scrub right over the site back and forth.
Oh, she did that.
But that's because she was doing a pick, and she was using
The swabs. She was using the swabs.
And it was what? And it was
Iodine.
Iodine. This is chlorhexidine. Two different surfaces.
Oh, okay.
You just scrub it, and I can't do it because, but you'll see them. They'll just scrub that site. They just scrub it.
And it's sutured in.
It's
So.
sutured in. This one
Most
isn't
times.
sutured in. That's why I'm holding on to it so it won't go. But you actually do vigorous motion back and forth. Back and forth. That's the difference when you're dealing with. There you go. Yeah, go. Right after you get your gloves on. You gotta have the right glasses. These people are
I'm not.
This is the end of semester. So then you do what? You want me to blow on it to let it dry?
No, let it dry for 30
Okay,
seconds.
You gotta let it dry and things like that. So you let the patient know. Now what you do, some people, and I'm for to speed it up, we're gonna go ahead and dry this site. Okay?
But not in real life.
Not in real life, you just got to let it.
And not in check off.
Not in
Mine check out.
So don't make it too wet. I made mine very wet, but you gotta dry the site. Because otherwise we ain't gonna get through this. What else do you want to do after this?
Little thingies.
Right, little thing. And here it is. This is the hand that I. So you have to kind of.
Put your bar
It
patch.
is what. And this is gonna be a fight to do. But you can do it. You're nursing students. Okay? Just watch him so he don't fall out on you, okay? The blue side is up. Okay, so after that you
Blue to the sky.
blue to the sky.
Blue up.
So we have to use that for that.
Then you go ahead and put your dressing on.
Dang. That's a whole lot easier than the video.
Mm-hmm.
Had so many steps.
Remember, she had an anchoring device and all that stuff. We don't have that here. If you have that, then go ahead and change that anchoring device. But a lot of times you'll just see, if it's sutured in, they won't use an anchoring device. They'll use that on a PICC line. Okay? They'll use the anchoring device definitely on a PICC line. So at this point, you got to what?
Label it.
Label it, sign and date it. So you can take your gloves off if you want to. Put your initials on here. But you don't need to be sterile anymore. Throw this away.
So sterility can stop after we put the chlorhexidine and then you attach.
Yeah, take it down.
Dressing on.
Put your dressing on. Put your dressing on, yeah. So then hand hygiene, you can put on clean gloves. Go ahead and sign and date it. Make sure when you put this thing on, you don't put it over the site, okay? Make sure you leave it so the next person can see the site. Because some people put it just like this. You can't, so you need to put it off to the side. Put it down here, sign and date it, okay? Sign and date it, wash your hands. You can take your gloves off, you can take your mask off. Go ahead and you got to do your documentation, but that is how it should look when you finish, okay? So go ahead and reposition the patient. You got to do your documentation. What would your documentation say? Like I said, if you got to change your caps, if you had to change your caps, you should have, I would have changed my caps before I even started. Okay, I just would have changed my caps before I even started. Okay, but most times if they're green, pretty much they'll tell you when to change them and how often to change them. Okay, so after that you can lower his head, you can take his mask off, document the findings. Pretty much that's it. What's the questions?
What would you use if a person is like allergic to tegaderm or something like that?
Well, when they have been allergic to, and then they have used just a gauze dressing, just like a 4x4 gauze, you know. But that's tegaderm is the only thing that's going to really secure it down tight like that and keep the moisture. Other than that, I've seen them just use a 4x4 gauze. But then you're changing it every day, if not every 8 hours.
Well, that's going to be annoying.
That's going to be annoying.
I gotta make sure I don't get sick enough to get a central line because I'm allergic to tegaderm. It burns me.
Oh, does it?
I still have the burn on my hip from when I had my second daughter.
Okay.
When I found out I was allergic, it's a complete like scar now. It's like it had a big old blister.
So you
And
probably going to have somebody who has to change it for you.
yeah, it's
Yeah,
awful.
you have to get somebody to change it for you because they only go to a 4x4 if the patient is, but because you're out, you just have to say, hey, change this for me because I can't do tegaderm.
Yeah.
Okay, yeah, but that's a good question. But that's what it is. It becomes just a regular 4x4 gauze because tegaderm is breathable, even though it doesn't look like it. It's still permeable. It's still breathable. So that's why you go with a 4x4 gauze and you put just regular tape around it. Just regular tape around it. But you will have to change that. If not every day, probably every 8 hours.
Yeah.
All right, so that's your central line. And like I said, central because of where? Because it does what?
Superior vena cava.
Superior vena cava. That's what makes it central. Okay. Other than that, it is considered. If it moves out here, my PICC line is peripherally inserted. It started here. It had a long catheter. They put it all the way up here, and when it rested in superior vena cava. If it's good, if it's central, I can shoot me an X-ray and it says it's in superior vena cava. Okay. And I said, good, we're good. I can run anything I want to with it. Okay, I don't have to say I can't bolus this. Yes, I can. I can bolus this in one room and turn around and give something else. So yeah, I have a lot more access available to it. Okay, but then again, I have opened this patient up to what?
Infection.
And it's a big one. Okay, it's a big one because I don't have to say is it systemic. It's already in the bloodstream because I went right in the bloodstream with it, right? When you went on and sneezed, when you sneeze, you put it right here. I'm sorry. Like you can't sneeze and shit like that. Well, okay. So central. That's why it's central. But like I said, it's various forms of central. But if you got to draw blood from it, and that's your protocol from where you work at, you can draw it from. Then you have to draw it. You have to draw it and give it to your phlebotomist. Okay. Okay.
So what about the ones that they from the
groin
area?
Groin area, that is, you won't get an X-ray on that because you have inferior vena cava, and this is basically sitting in it. It's going to feed right femoral artery, and the femoral artery runs where? I ain't gonna ask y'all no anatomy, but the femoral artery. You got inferior vena cava, and you got superior down here, and the femoral artery is right next to what? Right next to your aorta. It's right next to your aorta. It goes into your aorta. Then you remember how that looks? You got that there. It goes into the aorta. That's what it does. Largest artery in the body. Yeah. So they will put it.
Sure does.
Yeah, it should. Yeah. Imagine that. So if you have it there, and like I said, that's considered a dirty spot. That's considered a dirty spot.
Last resort.
That's the last resort. That's the easiest vein to get in a code. That's where they're gonna go. Okay, they're gonna go right here in the groin area. But it's the first one, and it's a protocol. If you stuck someone in the groin and put in a central line because it was a crisis situation, you have like a day or so to get it out of there and put it in a different spot because they're gonna get infected down there. Absolutely, they're gonna get it. That's a good question.
Because we had a patient who had like the dialysis catheter, both of them were gone. They couldn't get one here, so they ended up doing 2 here, and they had to change it every 8 hours.
That's right, every 8 hours. Yeah, because that groin is considered dirty.
And we don't insert the catheters ourselves. The doctors do that, right?
No. Now, what happened with central lines? No. But PICC lines, a lot of nurses are PICC certified. And they are inserting those lines, okay? They are certain, and they'll use like a sonograph and things. But yeah, central lines, those are healthcare provider. Most of your physicians or something like that are inserting those. PIC lines, your nurses can insert those. I'll tell you something, if you walk up on someone and you have stuck them a couple of times and they got Band-Aids, they, start thinking, this is person a candidate for a PIC, okay? That's why they ask you to stay away from the AC. They tell you to start in the hand, because those are the sites that nurse is going to use to do their peripheral insert. And if they come there and those sites are already blown, then they don't have really too much to deal with, But if your person is a hard stick or something like that, they're going in and drawing blood, start thinking, is this person a candidate for a PIC? In terms of how long something can stay, when you have either that inner groin or this one here, this single lumen, like I said, they call it triple lumen, those can only usually stay about 5-7 days. They got to go. They got to go. They're short term. They can pull out and things. If you got a PIC, that PIC can stay with you. That's long term. They go home with a PIC. They tell you, I had my PIC for 6-7 months. If they have an implanted port that they've had chemo in, that's when you see that port. I always say, if you see a port, they say, I got a port. I said, why do you have a port? Because that's telling me something long term, like you said, something long term. And then they say, oh, I had, because I had cancer and I had chemo, but I'm not treating that. But that port is still there underneath the skin. It just needs to be accessed. You have to have permission to access that. You have to be, some places you have to be certified as a nurse to access. Nurses are the ones that access that port. But that port can stay for years. It can stay for 5-6 years. Easy. I think my cousin had a port for, I think, 4 years. No, she had it for 5 years. I had a port in me for about 6 years. Okay, and a port in me for about 6 years. Okay, so the port can stay.
I had another question.
Sure.
So when we're doing check-off for check-off purposes, the outside of the catheter, that's not sterile, right?
No, this is not sterile.
Right. Okay, so if we touch that, our hand is no longer sterile,
Right.
so we have to use the other
Okay,
hand.
that's what you use, yeah.
So it's like kind of like the other one.
Yeah, kind of like the other one. Yeah. And the only thing about it is, typically this is sutured in, so it's not going anywhere. But anytime you tug on this, you have to make sure you're securing it. You can hold it down here, clean here, back and forth, back and forth. Therefore, I haven't done anything to this. Okay, I can't let this go all the way out here. Next thing you know, I'm getting contaminated. Okay, so but definitely it's a rigorous back and forth messing when you do it chlorhexidine. Okay, when you use iodine, you're doing a different approach, like they did the circle and things like that. But if you're actually going to their website, they'll tell you, move it just like that, back and forth. Okay?
I have another question.
Sure.
So with one hand being dirty, when we apply the dressing on top of the, what is it called, the insertion site, how do we do that? Because we're going to need both of our hands.
Yeah, that's it. So you pull it off. When you pull it off, you got a 1-inch border. Still got a 1 inch here, so you go here. I just picked it up here, right? And I moved it here and put it down like that. I haven't touched anything.
Okay.
You get what I'm saying? So
you because stay away from the actual line.
Yeah, you just stay away from, I don't have one here, but you get it on the edges.
Gotcha.
You get it on the edges. And like I said, you can use the other to pull it off, but you have to hold it on the edges. And when you hold it on the edges, like this, you can easily move it here, never touch that site and put it down. You're going to need 2 hands, absolutely.
Okay.
And I use 2 hands to put it on. You can't one hand take it down. People will try it, and then it balls up on you.
So let's just say you started changing and you realize that it's actually further out than what it's supposed to be.
Is what?
The line that's actually the lumen's actually further out than what it's supposed to be. So at that point, at that moment, you would stop, get them to reinsert it, or what would you do?
I'm going to go ahead and finish dressing it, and then I'm going to note that this is too far. Follow up, get an X-ray or whatever like that. I'm not going to stop anything unless I know that before I started messing with it, But if I got it taken apart, and that's when I realized, oh, this thing has come out via me pulling it or something like that, then I got to finish dressing it. I can't leave this unexposed. Gotcha. So I need to finish dressing it, but I don't go pushing it back in there.
No, just
I make a note that, hey, look like I moved it and things like that. Maybe I need a chest X-ray or something like that. Now, if I measure it before I've taken the dressing off and I see that it's further out, I might need to go then and shoot me a chest X-ray and make sure it's still sitting in there. Okay.
And that's something you would request, right?
You request to be like, what? They said he was sitting at 15 centimeters. I just brought again, and I got like 18 centimeter catheter on outside of the insertion site. I moved 3 centimeters according to this. Am I still in the superior vena cava? Okay, so they'll tell you if you're still in there. They'll tell you distal, blah blah blah. If proximal superior vena, I don't care if it's proximal, if it's distal, it's in there. It's in the superior vena cava. That is the final, So but if I haven't dressed it and I thought I'd pull on it and things like that, then I'm gonna have to go and finish my dressing and figure out how far I'm out. Go ahead and get me a chest X-ray. Okay. When in doubt, like I said, don't use it. Don't use it until you know it's right. Until you know it's, and if this line, like I said, and they'll tell you about if this line goes further down, you can get dysrhythmias from this line. That means the person can have EKG changes and things like that because it's now maybe sitting too low in the superior vena where it's actually because they'll say entering the proximal atrium, and then I'm too far down. Okay, I can't reposition that. I cannot reposition that. I have to call a healthcare provider to reposition this and tell me it's too low according to his x-ray, because they'll put this in at the bedside, tell you to shoot an x-ray, you find out that it's too low, you have to call that person back and say my x-ray is not, where it should be. If it's a PIC, and that's a lot of times nurses do PICs and they're PIC certified, when they get an x-ray or sonogram and they know it's not sitting there, and most times they're looking for that, they'll come back and they'll reposition us. Us as RNs, we just can't reposition.
I wanted to ask a question about that. Why is it I've had a couple of patients who are on telemetry, and the PIC line nurse will come and they will ask me, are they AFib or sinus rhythm? Because if they're AFib, they can't do a sonogram to see if the PIC placement is there. They have to do a chest x-ray. Why is that?
Because the AFib is going to show movement.
Okay, and they won't be able to tell what it is.
It's in real time.
Yeah.
It's in real time. So it's going to do this for them on their side. So that looks like, so what they're going to have to do is send a chest x-ray, which is a still shot. Okay. And let me see if it's resting in there. Okay. Absolutely.
Yeah, because they get really excited when they're sinus rhythm, like, yeah, I can do an ultrasound.
Yeah, right, because you can do an ultrasound. Sinus rhythm, I know that's a regular rhythm. I'm going to have some consistency. I can lay it on there and just wait for to pick up the sinus rhythm, and I should be AFib. He's all over the place. AFib, I'm all over the place. It's irregular to be irregular. Yeah. So I'm like this. So when I put this, I have no consistency. Okay. So at that point, that's when I need a still picture and an X-ray to see where it's sitting at. Okay. Good question.
I have another question. This might be a dumb question, but so we have to stay in the superior vena cava, right? But if you say we go into the heart, I get the rationale why going to the heart is bad because it causes defibrillation or whatever. But being that the superior vena cava is connected to the heart right there, and the flow is going to go that way, how is that not causing it as well?
No, because when you're actually inside of the atrium, okay, when you're inside the atrium, what happens? Superior vena cava, think of it like a tube. Here. Yeah. It goes here. When I get in the atrium, it's a big spot. Here, that catheter is going to go just like this. So therefore, it's going all across that atrium. Okay. When I'm here, superior vena cava, everything's flowing here. I'm just right in here. I have no movement. Once I move down here, I'm dealing. And what happens with the atrium? It contracts. Yeah. Right, absolutely. So when I get into the atrium here, that thing is like this. It's contracting. So it's really irritating the atrium. Throw your patient right in the AFib. Okay. Going right in the AFib. Throw him in the AFib and then throw you a big old clot. Yeah. Okay. That's why he's got to get out of there. He's got to get out of there. He's got to get up into his superior vena cava, and he can rest there. Okay, he can rest there. Absolutely.
So whenever in the video they clean this little area too, do we need to clean that guy with the chlorhexidine?
Yeah, you clean all that. You just clean it all across there. Anything that's underneath that you think is underneath your area or whatever.
You take it down.
You take it down.